You're listening to ReachMD, and this is COVID-19 on the Front Lines. The following episode has been brought to you by the American College of Chest Physicians.
CHEST is an internationally trusted source for clinical updates and advancing patient care across the landscape of pulmonary, critical care, and sleep medicine. With clinician members at the center of this pandemic, we are closely monitoring COVID-19 and regularly making resources available to help you navigate the challenges of this public health crisis.
Howdy, this is Victor Test. I'm the Director of Pulmonary and Critical Care and at the Texas Tech Medical Center in Lubbock, Texas. I'm also privileged to be on the Board of Regents at the American College of Chest Physicians, or CHEST. Today, we're hosting a webinar with Mr. Andrew Klein, who is a clinical nurse specialist in respiratory therapy at Chicago Rush Presbyterian Medical Center. We're pleased to have you, Andrew. Thank you for taking time to join us. I know you're busier than a one-arm paper hanger up there.
Yeah, thank you, Dr. Test. I appreciate you having me on.
Andrew, why don't you just kind of tell us, give us kind of a general overview of what's happening there in Chicago?
Yeah, so as we kind of talked about off camera, Dr. Test, we typically have 4 ICUs that we run that are fairly separate. We have a neuro ICU, a surgical ICU, a cardiac ICU, and a medical ICU, and we pretty much run the kind of patients you'd expect through those units, and so it's busy and steady, and we pretty much have a good system down for how we're going to deal with those patients. And so when this coronavirus epidemic happened and turned into a pandemic and started sending patients our way, we really had to take a step back and make a lot of changes around there.
Sure, yeah. Here in the South Plains, we're a little behind, lagging a little behind you in terms of case numbers and load, but of course we anticipate a surge probably a little bit later than y'all are anticipating in cases and burden on our ICU. Can you tell us a little bit, Andrew, about how your normal respiratory practice on mechanical ventilation and ICU care goes for our listeners?
Sure. So we enjoy a fair amount of autonomy in terms of our ventilator management. We have a ventilator protocol, and we have a weaning protocol, and we also have a proning protocol. So we pretty much operate under those protocols with pretty minimal physician direction. And I mean, they're around, and we do speak to them, and we keep each other in the loop on what the plan's going to be for a certain patient or patients. But the respiratory therapy department, we do a lot of that on our own. So we're sort of used to seeing a patient, optimizing them on the vent within our protocol, and sending the necessary labs to confirm that we're on the right track. And then we talk to the team and hey, what's the plan? What are we doing tonight? We're just gonna kind of get them through the night and look at waking them up in the morning. Okay, cool, let's do that. And that's typically how it goes, really, in all 4 of the units. We just kind of get the plan together once we get them tucked in on the ventilator, and then we just sort of run that plan. And if we have any hiccups, we loop the physicians back in. But if everything goes according to plan, we pretty much take them through mostly start to finish on our own.
Wow, that's a nice approach, and I think illustrates a lot, of how we're going to have to deal with crisis circumstances like we're currently facing. The team-based approach and interdisciplinary approach with respiratory therapy, nursing, physical therapy, physician extenders, and advanced practitioners in the ICU is crucial as we deal with this challenge. That's a very admirable way to build your program. So that's something that's almost aspirational for many of our programs. Can you tell us a little bit, Andrew, about how the last 2 weeks have altered your practice, or what kind of effect it's had on how you are doing things?
Well, that's a great question, Dr. Tess, and I can tell you, as somebody who's been around a little while, and I've worked at a couple different institutions, and we've had things come up where we've had to, implement things with a short time frame, or change things around or move things around. But I don't know that I've ever seen anything quite like this. We started out, we had we had a wing of our medical ICU that we built a few years ago for the Ebola scare that we had. I think it was around 2015, 2016, around there. And it was all negative pressure. It was 4 rooms. We were just going to put the Ebola patients back there. We had a plan for how we were going to deal with them, and so that was already there. So initially we said, hey, let's just put the coronavirus patients back there. Well, I think it was pretty conservative thinking to think that those 4 rooms were going to house everything we were going to get, because that lasted about a half of one shift. And then we realized that we were going to have to figure something else out. So initially, they opened half of the medical ICU and put some doors in where they split it in half, and half of it was going to be for the coronavirus patients. The other half would be for the typical MICU patients. And then they realized, okay, well, that's not going to be enough. So then they opened one of the general medical floors. Turned out it was an ortho floor, so then it was staffed with ortho nurses where we were going to put the non-critical rule-out patients. So then that happened, and then the command center decided, okay, well, none of this is going to be enough, so let's figure out where we're going to put all these people. So since then, and this all happened over the course of probably 4 or 5 days, and then they met and realized that wasn't going to be enough and said, okay, so we're going to open some of these floors that we have that are kind of equipped to put patients in that we don't really ever put patients in. And so they opened 3 of those floors, and the medical ICU is now just coronavirus. There's no actual medical ICU patients that go there. So, and we've also taken to sending a few of the critical overflows to negative pressure rooms in other ICUs. So I would say over the last 2 weeks, all of those things have happened. And we've had to sort of move our staffing around because our surgical ICU doesn't need quite the staffing that it used to need, because we're not doing any elective procedures. So there have been fewer cases come out on ventilators. So obviously we don't need as much staff support up there. So we flexed them down to the medical ICU. The charge person typically the last 8 or 10 days has spent most of their shift down on the medical ICU floor. So those are some of the things that we've really had to implement, and had to just sort of change how we staff and where we put patients. And we've had to rapidly implement our proning protocol that in order to include more of the nursing staff. So these are just some of the changes that have just happened day by day. People are coming in on their off shifts to help with training and picking up extra shifts to help with coverage. And we've upped our core staffing. We brought in agency, and we've developed a plan moving forward that we're calling our surge plan, that we sort of talked about last night. So a lot of moving parts and a lot of things pretty much changing day by day at our place.
Yeah, that's both daunting and impressive. It's nice that your hospital had the ability to expand into areas that were not already taken by other patient care. A lot of places don't have that option, but I guess that also emphasizes the need for planning and ahead for those of us who haven't begun to feel the brunt of this particular problem. Can you talk a little bit about the effect of the burden of patients has had on your protective measures for your respiratory therapist and your healthcare team?
Yeah, that's another good question. So, like I assume a lot of places have had to do, we've had to take a good hard look at what our availability of those protective resources are, and what we actually need as a minimum to protect our staff members that are taking care of these patients. And I think that our initial plan was a little bit too ambitious in terms of what we would be able to do and sustain as more of these patients were coming in. So I think our command center has had to create more of a conservative approach based on that, to how our staff members protect themselves, and when you actually need to ramp up to a higher level of protection, and when you can get away with the basics, and in terms of like doing a certain procedure, taking care of a certain type of patient that might be a rule out versus somebody that is positive, and different things like that they've looked at, in order, I think, to make sure that those resources continue to be available as we see more of these patients come in.
Well, I think, we're all, everybody across the country is sort of running into that same dilemma. We have the ideal of what we would like everybody to be able to use in personal protective equipment, and then we have the reality of what we can do and sustain. And of course, that's very frightening to everybody in the healthcare environment. We've had to make plans based on limited supplies almost from the beginning, and we're not nearly as far into this as y'all are in Chicago. Can you give us a little advice on how the Rush Medical Center approaches proning in terms of nursing and personnel, and do you have a team that does that, or is it the ICU nursing and respiratory therapy that make that happen?
So that's an interesting story too, Dr. Test, how that materialized. So one of my partners, Tyler, who also does some work out at Chest in his spare time, like I do. So him and I, for basically about the last 5 years, have been working sort of behind the scenes to try to get a proning protocol together where we could more easily utilize proning, because prior to that, we utilized the rotaprone bed, which was a personal preference of the leadership in our medical ICU, where we did most of the proning, and it was implemented before he and I ever went to work there, and that was just what they had always done, and they had a fondness for it, but it created a lot of barriers because it took a long time to get it ordered. It took a long time to get the patient tucked in it, and a procedure that shouldn't take a long time was taking a long time. So we had always had the idea, and we'd even written a loose policy, trying to get that implemented. So once this coronavirus started to become more real here in the U.S., and we started to see the writing on the wall as to what we might have to deal with, one of our physician champions kind of stepped up and said, "Listen, this is just going to have to happen. We're going to have to fast track this." And luckily, we had some of the infrastructure in place. And Tyler, along with a couple of our ICU nurses, stepped up and did some rapid fire training over the first couple days as these patients were coming in. And it just happened to coincide with the first blast of patients that we got. So we were able to get some hands-on training as we were doing the sort of the mock training. And so it was very sort of a crash course. And over that first 3 or 4 days, because the volume was so high, I want to say we had that first 3 or 4 days, once we started this, we had about 15 patients come in that needed to be intubated that were either high suspicion or confirmed coronavirus patients, and we proned about half of those people within the first few hours that they were on the ventilator. And around that, getting them prone, getting them supinated in the next shift, and all the turning that took place, we were able to get a high percentage of that medical ICU staff, as well as our respiratory staff, pretty comfortable pretty quickly with doing it. And now we've moved on to doing some crash course training with the ICUs that are taking some of this overflow as we get more of these patients in. So I think that in some ways this disaster has been kind of good for moving that project forward. And now as we get through these coronavirus patients and hopefully save a lot of them, because we're able to do this so effectively now, we'll have this in our tool belt to use on our normal ARDS patients, and so we can take a little bit better care of them as these coronavirus patients start to not need this high level of care a few months from now, hopefully.
Well, thank you, Andrew. That's very impressive. Can you just one last question, and I'll just say for the audience that we didn't talk about this question before, so this is a surprise question. It's almost like an Easter egg. So Andrew, could you just briefly tell us about how y'all are utilizing rescue therapies like nitric oxide and inhaled prostacyclin in this subset of patients?
Well, that's a good question too. I think we are utilizing all of these therapies in accordance with the directives that the Society of Critical Care Medicine came out with a couple weeks ago or a week ago. I can't remember when it was, but anyway, they had published or made available to the healthcare teams this pretty concise. Well, part of it was concise, and part of it was 104 pages of recommendations that covered literally everything that you might run into with a coronavirus patient. And it was kind of an expert panel that dug through the research and sort of summarized it for all of us. And so we use that to sort of build our own kind of mini protocol for these patients that dealt with pretty much anything that they might need, from fluid if they needed it, to steroids, anything and everything, vent management. So as far as the nitric oxide prostacyclins, they discourage the use of prostacyclins more for the aerosol generation than for anything. I will tell you there have been a couple patients we have used it on, but mostly in our patient population that we've had so far, we basically just use it till we can get them prone. So, and then we wean it off once we get them optimized in the prone position, because a lot of them come in, and I don't know how the people who will be listening to this, I don't know what their patient populations have been, but ours have been intensely sick. And we've had multiple patients out of our group on 16, 18, 20, 22, 24 centimeters of water pressure a PEEP to keep them within goal saturation. So there have been a couple, though, that until we can get them lined up and get them proned and things, they needed that little boost to get them oxygenated well enough to get them through till we could get them proned, and then we've been able to wean it off shortly after that. Other than that, I think that the best thing, the thing that we've seen in our patients, and the thing that has been most highly recommended in these guidelines, is high levels of PEEP and early prone positioning, along with early intubation, and skipping some of the steps prior to intubation that we might normally utilize on other patients, have been the most effective. We've intubated very quickly. I've been very impressed with our team, how quickly they've intubated these people. They've skipped a lot of steps and just intubated them right away. We've gotten them prone very quickly, and I think that's something that we've seen some success with, because knock on wood, as of now, we haven't lost one in our facility. So hopefully we can continue to utilize those guidelines and have some good outcomes. That's the goal.
Well, Andrew, thank you very much for taking time to help us and help us understand the challenges that we all face. I think I know I'm personally grateful for your input and your insight into how to approach this very difficult problem. And we all recognize that we're all in this together, and together we'll move forward. So, is there anything else you want to say in closing?
Well, I thank you also for your time, Dr. Test. It's been great sharing some ideas and talking about the sort of the differences in our facilities, and just recognizing that everybody's going to have their own unique set of issues, along with the bigger issues that we'll all have together. One thing I've noticed, just kind of as a peripheral idea to this, there's been a lot of sharing of ideas and collaboration on social media. I've had a lot of my colleagues reach out to me. I've reached out to colleagues that I have that I touch base with periodically, and I just think this has been a very a great example of collaboration, and something that we all recognize is bigger than any of us individually. And I hope that continues. And I think that this webinar that Rob put together, and we definitely appreciate Rob donating his time and his expertise to putting this together and sharing it with everyone. But I think that's been one of the big things I've noticed, and I hope that continues. And I think that's going to be something that helps us all get through this.
All right. Well, thank you very much, Andrew. And thank you for our organizer from CHEST, Rob Rabito, and for CHEST and the American College of Chest Physicians for making this possible.
For the latest CHEST updates, guidelines, expert advice, clinical resources, and more, we invite you to visit our COVID-19 webpage at chestnet.org. Thank you for your service, and please stay well.